Welcome to Deeper. This is an episode on all things sex brought to you by Adam and Eve. I'm Dr. Jenni Schuyler. I am the resident sexologist for Adam and Eve. I'm a licensed marriage and family therapist and certified sex therapist. We have a great show for you today. This is my dear friend and colleague, Dr. Craig Heacock. He is a psychiatrist in Fort Collins and runs the podcast Back from the Abyss. So today's episode is on sex and depression. Doesn't sound that sexy, but it's a really important topic because this is a hard time we're living in. This has been a hard time with the pandemic. It's a hard time in the world, and there's a lot of people struggling with a lot of mental health issues or just kind of touching those low-level depressions, if not higher-level depressions. And that can really impact your intimacy and your sex life. So for that reason, this is a really important topic. I've brought best expert possible on this, and so what we're going to cover today is what is depression. We're going to cover a lot of how it impacts your sex life for sure, and then a lot of different treatment modalities. How do we treat this from a lot of different angles so that you have options on how to approach this? You don't have to be alone. You don't have to have nothing at your access. We want you to have options and a lot of accessibility. So that's what we're going to be doing today. Again, what is depression, how it impacts your sex life, and how the treatment modalities affect you as a person and how it impacts your sex life. Because some of the treatment modalities don't impact your arousal and orgasm, and that's a good plus. So without further ado, I want to welcome Craig.
Thank you.
Dr. Heacock, welcome to
Good
the
to
show.
be here.
It's so good to have you.
It was so fun to do the last episode with you.
The last episode, if you didn't catch it, which we have posted here, I think on Instagram, certainly on our YouTube channel, is sex and SSRIs. How SSRIs, the antidepressants, even though they're really for anxiety, impact our sex life as well. Thanks. I learned that. Which is why we're doing depression here, because SSRIs are not that good for depression. Okay. Craig. Dr. Heacock.
Dr. Schuyler.
We'll call each other by first names. What is depression? How do you, in your office, define this?
Mm-hmm. So I think this is a key point that a lot of people miss, even a lot of docs miss this, that depression is not a diagnosis per se, it's a syndrome. So what I mean by that is, in a lot of ways, you could think of depression as like saying pain or saying fatigue. You know, it's a descriptor, but it doesn't get to the heart of what's causing it. So I think of depression as like a final common pathway. And how could you get to depression? And by depression, we mean sleep problems, mood problems, energy problems, libido problems, cognitive problems, energy problems. So how do you get to that?
Can I pause you before? How do we get to that so people can really identify what this is? It sounds like it is a set of symptoms that can vary. Mm-hmm. So if people were saying, am I depressed? What are the symptoms to look for? Mm-hmm. And then we can go for cause. What are they looking for?
Yeah, let's back up a little bit. Good, thank you.
You're welcome.
A lot of people think of depression as having a depressed mood or being suicidal or sad. But one could argue, I would argue, that the key symptom of depression is actually anhedonia, or the inability to engage in and enjoy life. Mm-hmm. Depression is a deadening of your ability to connect to your children, to connect to fly fishing or sex or reading or all the things that bring out your spirit, your aliveness. Depression just turns down that dial of engagement, and we say hedonia or
vitality.
Or fun, but vitality, right? So at its core, depression is a turning down of your life's energy and your ability to connect with the life energy of others and nature around you. So that is the core symptom. And then along with that typically comes sleep problems and mood problems and energy problems and libido problems and cognitive problems. But again, the core symptom, and when people come to sit down to me and say, I'm depressed, the first thing I'm always wondering is, do you have anhedonia? I mean, can you engage in or enjoy anything? And I think when people are in the deepest darks of depression, their favorite things feel empty, numb, flat.
Just for our viewers who are not maybe as clinically versed in the field, we're talking about depression and sex for those who just came on. And we're going to talk about treatment modalities, especially for impacting sex life. Anhedonia, I kind of give that a reframe or a synonym as apathy. How would you do a sort of non-clinical synonym?
I think of apathy as a lack of will or drive mixed with no energy.
Okay.
Sort of a nihilistic paralysis, if you will, kind of an empty paralysis. Whereas anhedonia, again, maybe a better way to think of that is think of your very favorite thing to do, the thing that where you feel most in the zone, most
Alive.
and imagine doing that and feeling nothing.
Okay.
And again, I've had so many people come sit in my office and I knew something was wrong because whatever, my grandkids came to visit last weekend, or
And you felt nothing.
yeah, or my wife asked me what's wrong, like you're not there.
Yeah.
And it's this numbness, it's this lack of ability, not just to experience enjoyment, but to feel engaged and alive. I mean, some of the most severely depressed people I see, when they first come, they'll say, I'm dead. Or I feel like I'm dead. Or again, it's interesting, the most depressed people are not sad.
Okay.
They're
not sad. I want to really clarify that. The most depressed people are not sad. They just feel numb
Nothing.
and dead. There's like nothing.
Yeah, right. It could, there could be some deeper well of irritability or sadness in there, but when I see people who are the most clinically depressed, yeah, in fact, they often don't even talk about being depressed. They're beyond describing that. They are, their judgment and insight is so impaired and they're so numb, they feel almost nothing.
Nothing.
Or just pain. Just bad. Like a lot of people say, what do you feel? Bad. Is it sad? Is it irritable? Is it dispirited? No, it's just bad, dead.
Can you talk about the difference between this being a condition that you are born with versus circumstantial? So like we live in a hard world right now. There's a lot of circumstances that can cause people to feel a lot of pain and fear and shoot us into a different place. Can you explain the difference between that? Or if somebody has a loved one pass away, sometimes they feel like they hit that depressive numbness.
Yeah. So we talk about depression as being a biopsychosocial illness, meaning it has, again, if you think of this final common pathway that can lead you to this syndrome of depression, you could get there through biological means, psychological means, sociological means. Biological means could be a genetic predisposition.
Okay.
For example, psychological could be trauma, attachment.
I'm going to pause you. I have an idea just for a metaphor, right? Let's say this is depression. It sounds like the different pathways that cause depression, right? So we have, just to kind of give a visual of what you're talking about, right? Okay, so.
Right, so biological could be genetic influence.
Okay.
It could be metabolic. It could be hormonal. It could be sleep disturbance. It could be epigenetic, which is a whole other discussion, which maybe we don't have time to go into. Psychological could be very commonly early childhood attachment problems. Mom or dad had some sort of psychological or life issue where they couldn't adequately connect. It could be personality structure. There's 5 inherited components of personality, and one of them is neuroticism, which is the opposite of resilience. So each of us come into the world on the spectrum somewhere between resilient and neurotic, or another way I think of that is, a lot of people think of that as dandelions and orchids. And some people are just bomb-proof. They're just super insensitive in the good and bad ways of that word, and some people are incredibly sensitive in the positive and negative sense of that word.
Okay.
Surprise, surprise, people who have more towards the neurotic temperament, orchid people, are highly overrepresented people with depression. And then sociological, a third one, biopsychosocial, that could be isolation. I mean, one of the things I'm seeing now during COVID is profound loneliness. Like a level of loneliness that I've never seen in my career. So I have people who've lived alone for years and they're doing fine, but now, relatively fine, but now with the fear that's just permeating the world and society, they feel so isolated. There's just like it's eating their core out. And we know, humans as a tribal social mammal, one of the ways to reliably put someone into the syndrome of depression is to isolate them. I mean, how do we torture people? We sleep deprive them, which makes people profoundly depressed and eventually psychotic. And we isolate them. Mm-hmm. And you put someone in solitary, you isolate someone, you can produce a syndrome of profound depression.
Yeah.
Which is very different than...
That's worse than torture. I mean, it sounds like solitary confinement is a worse form of torture than physical torture.
Yeah.
Which is probably why when people talk about neglect being worse than abuse.
Mm-hmm. Yeah. I did an episode on this topic on my podcast, Back from the Abyss. I did an episode on what's the deal with depression. One of the reasons there's so many people with poorly or incompletely treated depression is because the root causes haven't been worked out. Mm-hmm. Attachment problems, metabolic problems, hormone problems. Yeah. I just saw a woman the other day who sunk into the worst depression I've seen her in years, and we figured out it was because she had her Mirena IUD taken out.
Oh.
Yeah, and that's a rare thing, but some women are so progesterone sensitive, especially women in the bipolar spectrum.
Yeah.
Just having that taken out plunged her into nearly a suicidal depression. I thought I was going to have to put her in the hospital.
Wow. And I've had a few women go on Mirena and have that effect. Mm-hmm. And it's not common. No. I think Mirena IUDs are actually great if that's what you need for an IUD in birth control, by the way. And for a few people, I've seen them get one in and sink into a hard depression or even a suicidal state. Mm-hmm. I don't know if you've seen that.
Yeah, but depression is so common and so complicated. Yeah. So people might think, oh, I'm going to take antidepressants for my depression. Well, that might work depending on what combination of biopsychosocial influences you have. It very well might do nothing.
So biopsychosocial, quick review. Keep it simple. Bio, basically the biological pieces of us, our hormones, our metabolism.
Our genetic predisposition.
Okay, great. And
our sleep.
Our sleep.
Yeah, because sleep and mood are like this. Sleep and mood are chicken and the egg, peanut butter and jelly.
Wow.
In fact, I would argue, many others would argue, you can't have significant clinical depressive syndrome without sleep involvement. Mm-hmm. So when people come into me, oh, I'm very depressed. First thing I always ask about sleep.
Yeah.
And if people say I'm sleeping fine, then I think, okay, you don't have clinical depression. You have something. Yeah. But you cannot have a meaningful syndrome of clinical depression by any of these causes and be sleeping well. Yeah. Sleep and mood are so closely tied together. Yeah.
So if you have a bad sleep day, it won't send you into depression, but you can feel the effects of it.
Yeah, it's because depression, again, is not about depressed mood. The syndrome of depression is a full body illness that affects your metabolism and your energy and your volition or your will, your immune system, your sexual functioning, your processing speed, your short and long-term memory, your ability to learn, your ability to sleep, not just your libido, but your ability to be aroused sexually. All that is affected by the clinical syndrome of depression.
So let's talk that. Let's talk sex. We just had a comment that we're not 6 feet apart. We know that. We are also potted together, tested and potted together. So we are safe. Okay, so we've got the bio, the psycho, the social pieces of what happens in terms of depression and how that gets caused. How does that impact our sex life, our arousal, our orgasm, our motivation for sex? It sounds like if there's numbness, there would be nothing. There would be no incentive to want to have sex. Arousal could be circulating through your body and you might not even be able to track it or register that it's there, or register that it's there but not have the incentive to take advantage of it.
Mm-hmm. So that's such a great question. Let's just go through the key symptoms of the syndrome of depression. So let's start with libido. In general, people who are in a clinical syndrome of depression have little to no libido. Mm-hmm. except for people who are in a bipolar depressed phase, may have very high libido while still being deeply depressed, sad and hopeless, which is a very interesting phenomenon. So, when we see people that have a high libido, but they meet all the other depression criteria, that's pathognomonic or extremely suggestive of bipolar depression. But in general, I think of the dial of libido, wherever your dial is, clinical depression is going to dial that down.
Okay.
But it goes way beyond that. So we just talked about how depression and sleep disturbance are deeply tied together. And what we most often see is either A, insomnia, or B, hypersomnia.
Yeah.
So insomnia, what does that do? Insomnia wrecks people. Again, that's how we torture people.
Yeah.
And you're likely not to feel very sexy or wanting to engage with someone if you have not been getting deep, restful sleep. Because one of the core features, reasons we sleep is because sleep restores emotional resilience. And if you are not getting adequate sleep, you're not emotionally resilient when you start your day, and just all the little things of life wreck you even more.
Yeah.
Which is not going to make you more likely to want to have sex. Or flip it the other way, hypersomnia. Some people have
too much sleep.
Yeah, hypersomnia ironically tends to make people even more fatigued.
Yeah.
And depressed. So there's a sweet spot for sleep for us, and it depends on the person. Could be 6.5 to 9 hours, 7 to 9 hours. But if you sleep over your sweet spot, inevitably you are fatigued and
feel
lethargic.
groggy.
Right. Again, not likely to want to have sex.
Yeah.
And then another key feature of clinical depression is energy. Again, except for bipolar depression, people with the clinical syndrome of depression have little to no energy. Everything's hard. It's hard to take a shower. It's hard to walk the dog.
Yeah.
Even if your lovely lover says, let's do it, you think,
sounds good, but not really.
Yeah. And then mix that in with sleep deprivation and your libido dial already turned down.
How does this impact hormonal makeup? What about depression and testosterone? So testosterone is the sex drive hormone. Women typically have much less than men. And testosterone sometimes can override fatigue, like, I'm tired, but sex is a good idea. Or, I'm groggy in the morning. Sex, I can rise to the occasion. So how does testosterone impact this? Or maybe it doesn't.
With women or men?
Both.
Okay.
Maybe start with men.
Yeah. So in general, that's a much simpler thing to talk about with men. And one of the things I remember from med school is a lecture where they talked about, hey, if a man comes in your office, especially a man under age 40, be very concerned. Because men don't go to the doctor. Which has turned out to be very true. Another thing I remember in the same lecture about men's health, they said if a man comes in and says he's lost his libido, okay, it was here or wherever and it's down, be very concerned.
Okay.
Because that typically means something very serious is going on.
Okay.
So, and this is not true of all men, and some men have more of a complicated contextual libido, like from Come As You Are. I think we talked a little bit about that last session. But in general, men who come in with low libido, first thing I do is check testosterone, and I would say 9 times out of 10 it's very low.
Yeah, that's what my experience too.
And 9 times out of 10 they get on testosterone and they say, here we go. Oh my gosh.
I'm back to life.
My wife or partner, whoever's so happy, my lover, and I feel like myself again.
Yeah.
And then 1 out of 10 times maybe that doesn't help, and then that's a whole other exploration, oftentimes of psychological stuff, trauma.
Trauma's
I always
big.
think about that when
trauma.
Men with low libido don't respond to testosterone. First thing I think about is trauma. Yeah, because there's just so much hidden trauma. Women, it's a much more complicated issue. Clearly, there's some women that testosterone helps their libido and sexual responsiveness, but I think with women, particularly perimenopausal, menopausal women, I think of testosterone mostly as helping with energy, but more specifically the ability to recover physically from exercise. Because if you think of, say, that Tour de France athletes back in the day, or maybe even today, still injecting themselves with testosterone, why do athletes inject themselves with testosterone? It's not so they can have high libido, it's so they can work out every day, hard workout, and they recover and they build muscle and they recover. And so women I see in my practice, perimenopausal and menopausal women with a with an unusual amount of fatigue, or women who say, I used to run and now I run and I'm wiped out for days.
So athletic fatigue is when you treat it with testosterone.
Well, that's when I would be thinking about with women.
Okay.
Yeah, so I live in Fort Collins, Colorado, a lot of athletes there. And when I see women coming in who are saying, exercise doesn't do it for me. It wipes me out. It doesn't give me the sense of well-being. Then I often think, okay, maybe a little bit of testosterone. So then indirectly that could help their sexual functioning libidos because they just feel better about themselves. They can exercise more regularly.
Yeah.
So I tend to think of testosterone in women being helpful more to help them physically and help them be active and recover and just feel good about their bodies and their muscle mass. And then that secondarily helping sexuality.
Okay. So let's come back to depression. That was a quick aside, but it probably ties in. What happens then with depression and sex? How does that impact your sexuality most? What are the common side effects or impacts of depression?
Yeah.
Because sometimes people say, the treatment modalities are worse than the depression. And I don't know that that's accurate.
Yeah. Well, first, so we just talked about how the symptoms of the syndrome of depression can really wreck you
impact your whole
sexually.
life. Yeah.
But then interpersonally, you can imagine how guilt and shame starts to play this huge role. So you've turned your partner down a few times, or your partner could tell that you're just not into them. And then does your partner pull away or start asking you what's wrong, or start being angry with you? And then inevitably, as people get more and more depressed, they start feeling more ashamed, guilty. Like, this is more evidence that I'm broken. This is more evidence that I'm not doing my job well. Can't exercise like I used to. I'm not a good partner. And then that tends to spiral more and more down into maybe I'm too broken to have a relationship. So I think of this negative.
It's like a toilet
negative feedback loop that you
spinning
just get sucked down into, and everything sort of feeds your story and deep belief that I'm not coming back, and it's it's me, like I'm the problem. And this because this can develop slowly over months and years, and I see people that come to me with depression and ask them, when did you last have sex with your partner? 2 years ago.
Wow.
4 years ago. And have you talked about that with your partners? Sometimes yes, sometimes no.
Wow.
A lot of times no.
Wow. So, what if you're single? You've been single for a while and you have depression. Do you notice, how does that impact your sex life? Do you notice that in terms of your motivation or lack of for self-pleasure? Does it impact orgasm at all? What are the impacts on our human sexual response, if any?
One thing I'm seeing a lot, I think, let's talk about male patients first, because that popped in my head.
Okay.
A lot of my male patients, as they're starting to get depressed, again, lose their drive or just willpower to get out and try to meet someone. And so they go right to porn.
Okay.
Because if you're in bed, depressed, again, you're oversleeping or you can't sleep, and the thought of trying to find someone and meet them, like, just so exhausting.
Overwhelming.
It's so much easier for whatever remaining sexual charge you have left. Porn is just so easy. So
it's just an easy, accessible, quick discharge.
A lot. I would say, and then my men with mild to moderate depression, that tends to be where they go. And then severe, that just gets shut down, because that's a whole different category when you're in severe depression.
Yeah.
Women, I think it's more complicated. I don't know if I can say any gross generalizations about, other than that I think there's this just buildup of guilt and shame that what's wrong with me. A lot of women that start defaulting to body image stuff, like, I haven't exercised in weeks, or I'm starting to eat this really poor high carb diet, because guess what? When you get depressed, if you have insomnia triggers carb craving. So insomnia triggers carb craving, which triggers weight gain, which triggers guilt and shame, and anxiety, which causes more insomnia. So
Yes.
a lot of people in an anxious depression, which is typically an insomnia depression, are using carbs as medication. So then there's even more guilt, like, oh, what am I doing?
I'm overeating, I'm oversleeping. This is all contributing to the depression. One of the things I've found for women who seem to be in that, whether they're single or partnered, and they can't feel their access to their partner or life, right? If they're in that depressive place, I tell them to self-pleasure, because I think orgasm, the chemicals that come with orgasm do help a little bit. Do you find that to be true? Is that
I
a
do,
treatment
but
modality?
yeah,
To get there is hard.
Yeah. I mean, one way to think of just in general this sort of depressive syndrome is mild, moderate, and severe. But
Yeah.
mild depression, there's a lot of, I think having a sexual connection and orgasm, that could help. But once you get to more moderate, which I define as sort of moderate impairment or moderate misery,
Yeah.
it gets to be to the level that, okay, if you went for a 3-mile run, that would help you feel better, but that's impossible.
You just can't get to that point.
If you would just have a positive sexual experience with your partner or even with yourself, but it's just too much work and it's too exhausting. And again, as I mentioned before, clinical depression with bipolar depression accepted is deadening. Yeah. It's taking like all your life energy, your chi, your spirit, it's just dialing it down. And so people's sexual responsiveness comes down. I mean, you figure people sometimes don't want to eat. They don't want to shower when it gets severe. They don't want to brush their teeth when it gets severe.
Yeah.
The thought of, hey, an orgasm would make you feel better is sort of like saying, hey, if you jumped over this building, you'd feel better. It's like, so much work.
Is it more common, though, to have severe depression like you're describing, or low level? Because I find like the low level depression can spiral into a worse depression, and it catching it at that low level place and doing the treatment, which we're going to get to right now, catching that at low level can really prevent the severity of what you're talking about, which I think is important. So low level, like that's where it's like, come on, let's do a little self-pleasure or interact. Yeah.
Well, so if you're having mild to moderate depressive symptoms, there's a bunch of things that can help.
Okay.
And the first one is, and again, I just did a podcast episode on this, and the episode I did was called The Most Important Question in Psychiatry, and I talk about on this episode that if I could only ask my patients one question during a session, just one, it would be, what time do you get up in the morning?
I remember that episode. Yes.
And the reason is that gets to the heart of our sleep cycle.
Yes.
And it turns out that healthy people get up around the time the sun comes up or within an hour or two. People who wake up in the mid to late morning or afternoon are largely jet-lagged, fatigued, depressed, cognitively impaired, depressive. People who are waking up at 1, 2, 3 a.m. are really anxious or traumatized or withdrawing. So the first thing that can really help with mild depression is get on a sleep schedule. The thing that can really help moderate depression, get on a sleep schedule. The thing that can really help severe depression, get on a sleep schedule. And I probably spend more time talking about that with people than anything, because I tell people, like, look, all the things we're going to try to help you, if you sleep till noon, you're 5 hours jet lagged every day. Like your circadian rhythms are off. Your all your hormone cycling, the light dark cues, and if we, anybody who's been jet lagged, you know what that feels like. It feels like when you wake up at noon. So getting people on a regular healthy sleep schedule, it's actually very simple, but it's very hard. That's the thing that I tell people. That's the one thing I say
treatment
people
modality.
most cry when I go through all the things I want people to do. That's the people shake their head or they cry and like, I can't do that. And I say, okay, we'll get to that, but just so you know, we'll know that your depression's a lot better when you're waking up
with the sun.
An
hour.
Shortly there, because we are diurnal mammals. All of our hormone cycles are tied to light dark. We're not bats, we're not raccoons. But guess what depressed people do? They pretend they're nocturnal. And it wrecks us.
And that might be attached to trauma, right? The night might be scary for whatever reason, right? Your body remembers nighttime as a fearful place, so I'm going to stay awake to prevent whatever
Yeah.
memory trauma feels scary.
Yeah. Yeah.
And then you're ending up awake too much in the night and then oversleep in the day, and then we're in our negative cycle.
Yeah. Interesting study, I forgot, this maybe 10 years ago, showed that people who work the night shift through their adult life, they lose as many years off their lifespan as people who smoke 2 packs a day, which was like 10 to 12 years. Shortened
Wow.
lifespan. And that, if anything, sums up how toxic it is to stay up at night and sleep during the day. It's that. It's as bad as smoking 2 packs a day. Obviously, it has.
Yeah.
Actually, I would argue smoking 2 packs a day would be much better in terms of quality of life, because at least if that was just your thing, but you got good sleep at night,
Yeah.
you could still have meaningful connections and functioning sexuality and friendships and do all
Yeah.
that. But I just can't emphasize that enough, that if you want to start making a meaningful impact in your mild to moderate severe depression, you have to get on a healthy sleep schedule. There's no, and again, you may need to make some other changes first, including some other things we'll talk about, but
Yeah. Is the healthy sleep schedule, I'm seeing a comment come in around sleep, about what time you go to bed too, and how many hours you accumulate?
it seems that's a complicated question, but just a short answer is, there's 2 kinds of sleep. There's non-REM and REM.
Okay.
REM, dream sleep. Well, it turns out that REM is doing something really important that's only been discovered in the last few years, and that REM is the way we rebuild emotional resilience.
Emotional resilience.
Yes.
So let me just repeat that, because it's a really impactful statement. REM is how we rebuild emotional resilience. Mm-hmm. That's huge.
Yeah, but it turns out that most REM happens in the last 3 hours of your sleep cycle.
Okay.
But if you, let's say you sleep 11 to 6, that's 7 hours, or you sleep 3 to 10 a.m., that's 7 hours. If you sleep 3 to 7, your REM cycles are very seriously disrupted, and there's a lot of complicated reasons why. But 7 hours is not 7 hours. 7 hours where you're waking up at 6 or 7 a.m., you're much more likely to get your normal amount of REM sleep, and thus your restoring of your emotional resilience battery.
Okay.
And isn't it interesting, you think of people, and I can think of a lot of examples, people who sleep till late morning or early afternoon, it may be 8 hours, they're not emotionally resilient. They wake up and they're already kind of wrecked. They can't handle stuff.
So just to repeat that, even if you get 8 hours, if it's like 3 a.m. or 4 a.m. until noonish or something like that window, emotional resilience is low. Mm-hmm. Okay.
Yeah. So, and then of course there's a number of really other important functions of sleep, but I think that right there. So what I encourage people to do is set a wake-up time. Mm-hmm. 7 a.m., 8 a.m., 8:30, whatever, so hopefully before 9. And get up the same time every day. Mm-hmm. Because again, because otherwise, and I tell people ideally, plus or minus an hour. Because if your wake-up time varies between 7 a.m. and noon, for example, that's 5 time zones. That would be like saying, oh, I have a job where I fly from Denver, and the next day I'll be in New York, and then I'll go back to San Francisco, and then I'll go to the Bahamas, and then go to Chicago.
Yeah.
That wrecks people to just be across time zones back and forth. But
yeah.
That's what you do when you have a variable wake-up time. And again, there are people who are really young and resilient and don't have depression and are just professional sleepers who can get up anywhere between 6 a.m. and noon. I know those people, but they're not coming to see me. Mm-hmm. Yeah, those people are really fortunate. They're just super resilient, super sleepers.
Yeah.
Fine, good for them. That's awesome. Yeah. But I'm talking to people who struggle with clinically significant depression. Mm-hmm. I tell people, your sleep schedule for you is like diet for a diabetic.
Okay.
And so, if it's someone with diabetes just feasts on donuts, they're going to pay the price.
Yeah.
Big time. And someone with clinical syndrome of depression has an erratic sleep schedule, you're going to pay a big price for that.
Yeah. What are so let's talk treatment, right? So there's some natural treatment things that you can do in terms of lifestyle changes if you can motivate yourself to do this, right? So you're talking about natural treatment modalities. How do I just change some of my patterns so that I can actually get my depression in upward trajectory, start to feel life, feel meaningful connection? And if we don't have the motivation for that, it sounds like we need a bigger intervention. Mm-hmm. So natural natural things that we can do if we have the motivation to do it is sleep, right? Wake up at 8:30. Well, if
Or
you
wake up at the same time.
wake up at the same time.
Yeah.
6,
Ideally
7, 8, somewhere before 9 o'clock.
Yeah.
Wake up somewhere before 9 o'clock and then work backwards to make sure you go to bed to get 8 hours. So get your 8 hours and go to bed at a time that makes you...
Or at least 6,
Or 6.
Yeah. I mean,
6,
really...
because 6 is a good start.
It's so much better
Okay.
to sleep 6 hours, from, say, 1 a.m. to 7 a.m.
Okay.
versus get your 8 or 9 hours from 3 a.m. to 11 a.m. It's so much
that's
better to
so
get less
interesting.
sleep during the night when diurnal mammals should be doing that, because guess what? Then you have normal, what we call sleep architecture, or REM, non-REM structure.
Okay.
So we are totally creatures of this earth, and I think we pretend that we're not animals. And I mentioned this on a recent podcast too. I've heard many stories.
Just to pause for some, podcast is Back from the Abyss. It's amazing. Okay, go ahead.
Thanks. I've had many patients with really severe sleep problems and depression go on multi-day camping trips, backpack trips, hunting trips, and come back and say, you know what? I slept well. I felt great.
Yeah.
It was amazing.
Yeah.
I don't know what happened. And it was because they were outside all day, under the sun, getting all the light cues. Because again, we're diurnal mammals, and we evolved out in the sun. And then when it's dark, they settle down for bed. And when the sun comes up, they get up and they do their thing. And surprise, surprise, at least for mild to moderate depressive symptoms,
sunshine, outdoors, go to bed with the sun, wake up with the sun.
Right. Which again is still, if you're mildly depressed, but you talked about motivation, and I think, humans being such social creatures, we need each other. We deeply need each other. And, I tell my patients all the time, change is so hard, and it's so hard to do it alone. So don't do it alone.
Yeah.
Get a therapist, get a doctor, get a friend, get a trainer.
Yeah. But know what you're asking for, too, because I know a lot of doctors will just give out an SSRI, and I know that you really don't like that approach to depression.
Yeah, if for certain subtypes of depression, I tell a lot of my patients, I say, please, if you're serious about getting better, get a trainer.
A physical trainer. A physical trainer.
Yep. I see a trainer every week, because a trainer fills some really important niches. And I tell people, get your trainer in the morning, because A,
gotta get up
you get up in the morning. B,
them.
A lot of trainers, if not most, are very social, positive, engaging people.
Yeah.
It's like
they're kind of like therapists, right? They're like, work
and they're
out,
getting you
we're gonna
moving.
do this.
So they're actually solving 3 of the key problems with depression: the isolation, the lack of interpersonal connection, lack of activity. And if people can't afford a one-on-one trainer, do a class or something.
And even the Zoom classes are okay.
Right, but trying to do it alone, because so many people just come in with so much shame. I can't fix myself alone. I'm like, don't do it alone. I mean, that's why we have trainers and AA and therapists and divorce recovery groups and meetup. And how do we torture people? We keep them alone, And a lot of my patients, when they show up with severe depression, they're a mouse in a bear cage. And I tell them, you're a mouse in a cage. You need some other stuff in there. And a lot of times for my patients, like coming out of their little feed thing is weed or alcohol. And they're like, or carbs. Like, why do I just all day just consume this substance? Like, well, because you're a mouse in a bear cage,
I want to pause you with this, because I hear a lot of couples, and when I do couples therapy, I find that the loneliest people are in these very lonely marriages. It's like, I'm sleeping right next to someone, I live with this person, and yet I feel profoundly lonely, because there's just there's a disconnect. And again, chicken or egg, right? Is it that there's depression, so there isn't any feeling of connection, or are there other marital issues, so there's disconnection, and then in the isolation and loneliness, we get more depressed, right? So there's both. And so so when I do an intake form, I ask these couples, like, how much are you drinking? How much are you smoking weed? All those issues, because it's a barrier to connection, but also it sounds like it's exasperating depression.
Yeah. Or if you think, about coming to substance for a sec, the big problem with THC and alcohol is that they alter sleep architecture. So both weed and alcohol help you fall asleep. Great.
Yeah.
But then the key REM sleep hours, 3 to 6 a.m., 3 to 7 a.m., alcohol and THC, you tend to withdraw in those hours and you wreck your REM sleep. So what does both THC and alcohol do? If you use in excess, they wreck your REM sleep, which wrecks your emotional resilience. So how many people say, I need to drink to calm down, I need to smoke to calm down, to make me less irritable, so people don't piss me off, so I can deal with this fucking world. I mean, a lot of it. But I say to them, let's talk about your sleep first. And so many of them, no, I need to smoke or drink to fall asleep. Well,
Yes,
how do
I
you
hear
sleep?
that a lot.
How's your sleep between 3 and 7 a.m.? Not good.
Yeah.
Do you have dream sleep? No.
So having dreams.
Because
remembering
dream is REM
dreams.
sleep. So people who are not having much dream sleep, you can pretty much guess that their emotional resilience is very low.
That's super interesting.
And substances wreck REM sleep.
What about other supplements for sleep? Do you recommend any? Or are you like, no?
No, I do. I think magnesium for some people can help deepen sleep. There's a lot of herbal remedies, but here's the thing: anything you take for sleep, you're going to develop psychological dependence on it.
Yeah.
At least. And some medications you can develop physical dependence, but anything that you like, I need this to sleep, whether it's your concoction from your Chinese medicine doc or your whole food supplement, anything, you at least develop a psychological dependence on that, which is fine. I'm not, just so you recognize that. But in long-term studies of insomnia, what works long-term is what we call sleep hygiene. Getting up the same time, getting light, dark cues, putting yourself to bed. Because you think like little kids, we just don't stick little kids in bed and say sleep. Well, how does it work? We give them a hot bath, we read to them, sing to them. But guess what? Adults with insomnia need to put themselves to bed.
Yeah.
Take a hot bath.
Yeah.
Listen to something calming. But I think what a lot of people are doing, we're super wound up with the news or social media or video games or substances, and then we try to just go to sleep.
Yeah.
That's insane.
Yeah.
It doesn't work. So a lot of my adult patients with insomnia and depression, I tell them, you have to start putting yourself to bed like an hour before bed.
Yeah.
Because you have a really wound up
nervous
system, and you need to calm it.
Yes.
But that's, people like, oh no, I just watch TV and that puts me to sleep, or I play video games until I fall asleep.
Yeah.
That's not calming.
Yeah. I love to take a hot bath, and then I do a few stretches, and then I'll crawl into bed, and I have a heating pad that's just cozy, and my book, and I'm just cozy, and it's great. That's interesting. So I know we're close to time here. Let's talk about, so what I'm hearing in this, that the most important thing, if you take anything away, is your sleep. Your sleep hygiene really will help naturally fix depressive symptoms in this constellation of depression that can be biopsychosocial.
Yeah. And connection. Because if you think of there's theme in all this, if you're going to start pulling out of this negative feedback, self-reinforcing loop of depression, it's so hard to do it alone. For most people, it's impossible. You need your spouse or your friend or your therapist or your trainer or AA. Or an animal. You need, because some people, some of my patients have said, getting a dog's great because it makes me walk the dog, or it makes me get outside.
You have to get up early enough so the dog can pee.
Yeah.
Yeah.
But again, the nature of depression is to start to blame oneself and just feel so much guilt and shame. Yeah. So like, why can't I change these patterns? And I keep doing these things, and I can't sleep, and I eat more carbs, and I'm smoking more weed, and I don't answer my phone, and so people see the spiral, but it's just slow motion plane crash that they can't pull out of, and it's not their fault. It's because all the symptoms of depression lead you to get worse. Yeah. It would almost be like if as your arteries were clogging in your heart, the more that they stenosed and clogged, the more you crave McDonald's French fries. Yeah. Like as you got nearer and nearer to a heart attack, the more you just wanted to drink animal fat. Yeah. That's what depression does. The worse you get, the more everything that you do pulls you into this inevitable downward spiral. So let's talk, if we can't get out of the downward spiral, because I hear a lot of people say, I can feel the low level depression and I can't yank out, right?
what are treatment modalities and options for more severity?
So I think first thing is to look back and to say to yourself, when was I healthy? Now, some people will say, I've never been. That's one of the questions I always ask people when I first meet. When were you last healthy? What do you mean? Well, when were you last sleeping well and your energy was good and your sexual functioning was good and you're enjoying your life, looking forward to the next day? Now, some people say, 3 years ago or 2 weeks ago, or other people say, never. But that's an important question because it leads to, if you can think of a time that you were doing well when you weren't depressed, then the next follow-up question is, what's different between now and then? What were you doing then? What did your life look like? If we could watch the nanny cam version of your life 5 years ago versus now, what's changed? And obviously, what could you do to reproduce some of that?
Well, what if it's outside circumstances, like a death or a political atmosphere or a COVID atmosphere, and you can't control some of those things?
Yeah. I think connection is crucial, but positive connection. So one of the things I always give my patients a big sheet of recommendations. And one thing I'll often say is news diet, like no more than 5 minutes on news, or no more than 15 minutes on social media, or because what you're connecting to really matters. If you're connecting to contempt and anger and fear and outrage, and that's not going to help. If you're connecting to kindness and compassion and warmth and joy, that matters. So again, depression is an illness that pushes us into isolation. Everything about depression pushes us towards isolation. The way out of depression is to reconnect. But again, that's exactly what you don't want to do, but what you have to do. But as people get more and more depressed, what they often do is connect to really awful stuff. They go deep into their Facebook feed and read about how scary and terrible things are, how everything's falling apart, which then just reconfirms their worldview that everything's going to shit. And feeds their depression and their insomnia and their carb binging and their substance abuse.
It feels like we have a lot of depression going on in our world then. Like maybe a lot more than we actually recognize.
This is the worst time I've seen in my practice. I was saying to my wife the other day, who's also a therapist, it seems like no one is doing well. Not just in my practice, but everyone is struggling in some way just with this fear and just kind of doom. And a lot of that's being fed, I think, by
media,
social media, getting pulled in people's own silos of, okay, this is what's going to happen, and this is the terrible things that the other people are doing. And because what I tell my patients a lot is I say, look, go outside. It's beautiful. If you just look at the world on the internet, you think everything's going to hell, but you go outside, actually, the sun is shining, at least here it is. And things are okay. I mean, people are wearing masks, but we're okay right now. And get outside and do something. Get off your screen.
And here we are on a screen, except for this. So let's leave people with a message of hope. So I think it's really important to inspire hope and give some really easy, accessible, tactical solutions. What we're hearing with the tactical solutions, and I'm going to throw in a few more of my, if you can, touch your body too. Like let's say, so let's talk about tactical solutions, right? Go outside. Well, first let's go to bed and wake up for your 8-hour span, making sure you're waking up at the same time. Good sleep hygiene. Go outside and get fresh air. Even if you work inside, I've been telling some clients, like, yes, you might have a job that's on the computer, but set an alarm for every hour and go outside for at least 2 minutes, 5 minutes, and just breathe fresh air. That's why I think smokers actually have, you're talking about smokers, they have to go outside to smoke.
And it's often social.
And it's social,
Smoke
right?
breaks, they talk. Right.
I'm not advocating for smoking necessarily, but it's an interesting phenomenon of like, well, I'm outside doing this. Go outside, how often? So let's go outside. Let's go for walks. If you don't have an animal, go adopt one. I just adopted a doggie from this great shelter here where I live. It's a sweet dog. So many dogs need homes. Go adopt if you're able to.
Here's a hard one.
What?
I would say everyone who shows up in my office, first appointment for some sort of depression, I would say 85% of people are self-medicating with substances. And that's always a really important discussion to have. But as I said a few minutes ago, both cannabis and alcohol are sleep wreckers, but particularly sleep quality wreckers. And sleep wrecks mood, and sleep deprivation lacks emotional resilience. So I think job one for people, if they're realizing I'm not doing well, is to look at your substance use. And maybe even to check in with someone like wife, girlfriend, family member, like what do you think about my, because the thing is, if your substance use is causing you problems, that's a problem.
I always say with substance use too, one way to gauge if you're actually, like, your relationship to the substance, whether it's use, misuse, abuse, addiction, and I sort of gauge it on that spectrum, is do a sabbatical. Do a 2-week sabbatical. See how you feel. Can you do a 2-week sabbatical is the first question. And then if you can, how does that feel? Do you feel cleansed? Do you feel alive? Do you feel vital? Or do you feel like, that was really hard. I was white knuckling my way through the 2 weeks.
Yeah, I see with men in my practice, and I think men in general, that men, some small percentage of men have a meditation or spiritual practice that works for them, but most men that I know, to deal with stress and anger and everything of life, they either work out or they use substances.
Yeah.
And I think again it's more complicated for women, because women, I think, are more socially dialed in than a lot of men. But I tell my male patients, I say, look, you either got to work out or it's going to not go well with substances, and that's largely true.
Working out is a good. Here, back to our solution list. Working out is a great one for depression.
As long as it's mild to moderate, right? Once you get in the severe zone.
Yeah, addiction, exercise addiction.
Well, or then just you can't do anything. I think of,
Right.
Severe depression, telling someone, hey, you should walk your dog, or you should do anything. It's no way, because you're reaching a period or a point of sort of paralyzed hopelessness and despair. And then you're talking about very different kind of interventions.
Yeah, right. Okay, we're here at time. So solutions, quick solutions, your sleep hygiene, check your substances, do a substance sabbatical, go outside, take walks, breathe fresh air, take sabbaticals or shorten your duration of your social media.
Do an inventory, look back, when were you last healthy?
What was happening?
Yeah,
in
what
those
was different
times.
when you were last healthy? And if you've never been healthy, even more reason, I think, to seek some professional help.
And seek help. It's out there.
You need connection. This is a time of deep loneliness, and usually in times of difficulty or despair, we come together. I mean, we're tribal social creatures, and the pandemic is pulling us all apart. Social media is pulling us apart.
Yes.
So all these powerful forces are isolating us, which, surprise, surprise, leads us to more despair and depression. So you have to connect.
How do you connect, Craig? How do you connect?
Yeah. Well, first is, let's just talk about media. I mean, I love to read. I'm really careful about what I expose myself to. I look at maybe 5 minutes of headlines so I know what's up. I do not go down the rabbit hole of all the negative stuff that's happening. I know there's a lot of stuff happening. I read to learn. I read to challenge myself, to be inspired. If I start reading too much that's making me sad or despairing, stop. I love to run. I think hopefully we all have one or two things that really have brought us deep connection over the years, and for me it's running. And I found in my own life that either it's been like alcohol and running. Times when I haven't run much, drank way more. Times when I was running a lot, I drank less. And so there's this loop. And I see that in a lot of people I work with too, that the more physically they active are, the less they need substances.
Yeah. And if you can't run, walk.
Walk, just do something.
Walk.
Just, get outside.
Yeah.
Get a dog.
And if you are a wheelchair user, use your arms and wheel. Go outside and move your body with whatever abilities you have.
Yeah.
Yeah.
And I think connection, what we're really thinking about is positive connection, because what happens with depression is the connection that there is negative. It's to negative people, negative things, negative writing, negative websites. Just if the things you're connected to in your life are pulling you further down, you have to stop those.
How do you stop those though?
I know.
That's the secret, right? That's hard.
I mean,
Yeah.
one of the biggest things for all of us is realizing there's one thing to realize there's a problem, but the next step is to have the inventory and the insight to realize I probably need help. Someone, whoever it is, like it's so hard to make significant changes alone. It's just not how we're wired.
Yeah.
We have been living in tribes and community for as long as there have been people.
Yeah.
You know, we are not cats, we're dogs.
Yeah.
You know, but depressed people live like cats. They sleep on and off around the clock, and they isolate, and they, you know, and other cats that come up, you know. And I think healthy people are like dogs. We are social, and we get outside, and we are adventurous, and we try new things, and
we like connection.
And we like connection, and we even if we don't feel it, we try to wag our tails.
Yeah, yeah. Hard because you know in this time, a lot of the connection is on the screen.
Mm-hmm. But if you're connecting to people on a screen in a positive way, hopefully for those of you this is positive.
Yeah.
I'm all about positive connection.
Yeah.
And you know, for example, I see a lot of adolescents who play a lot of video games, and a lot of them will say, "Oh, these are some of my most positive connections. I play with my friends, and we laugh." And I say, "Great! If that's how if it's positive connection and you feel good, then great." Oftentimes the parents see, "Ooh, they're in the screen." Yeah, maybe less than ideal, but if it's bringing a sense of positive connection in their life,
yeah, great. All right, should we talk anything else? It's been a long time here. We'll do this again. We'll cover more details later. Thanks for having us. And we will post this either on our YouTube channel or Craig will probably post this on his website. And that podcast is Back from the Abyss. And I'll post it on mine, the Intimacy Institute. I'm sure Adam and Eve will post it on their YouTube channel. And you can review this again and really learn about depression, how it impacts sex. The one thing I'd also say is if you have the motivation to connect with yourself, that's connection too, right? That's a big connection with your body and your fantasies and your skin and your arousal and your orgasm. So I think that really is helpful too in terms of then feeling good. You release all of that, dopamine afterwards. So it's a good hit if you can do that. So if you can motivate yourself to have sex with yourself or your lover of whatever capacity that is, I think that's also helpful. All right, guys. Thanks for watching. We'll catch you next time.
Good job,